pathology, and I think it can be interesting for people, a surgeon or physiotherapist, to see why it's sometimes really a little special. I apologize for my English. I think that my slides are very well done, and so if you don't understand something, you ask. So what is arthrogryposis? It's a clinical sign. It's a very old way to describe what you can find when at the birth, when you have joint limitation. It's a rare disease, and just now we know that there is so many causes, and so it's we need to explore all these causes, because we have a different way to take care. It's a fetal immobilization consequence. So let's know. It's something which happened before the birth, and it's severity consequence. It depends on the timing of immobilization. If the pathology begin very early or sometime more later, and it can be a consequence about muscle, about nerve, and it have consequence about all this formation of joint cavity and maintenance, and so we can see what's going on. What it's occur, why it's interesting for us to know what's occur before the birth, because it's there is more than arthrogryposis, more than only the effect on the bone. You have a very gracile bone, you have a retinoitism, you have pulmonary hypoplasia, you have short umbilical cord, and when you know this is only chicken, you know that if you have pathology, you have this kind of development. If you are only joint immobilization because the muscle are cauterized, you have a different development, and you have this kind of development, and so you can see that the morphogenesis will do a different type of joints. And so after the birth, if the surgeon needs to do something, he had to know that he will not find a normal surgeon, a normal articulation, joint. And so you can see like this, and you can see also when you do anatomic so the different causes, we see that it's coming from cerebral medullary pathology, from the nerves, from the neuromuscular junction, from the muscle, and you have also connective and bone and cartilage pathology, and you have all the consequence on the joints of all this kind of pathology. So just now we know that arthrogryposis, one symptom, have more than 400 different causes. We have 3 kind of etiology. So the main clinical entities are the third group, amyoplasia. Amyoplasia, we know that it's sporadic, it's quite contracture and joint position. You have muscular atrophy, shoulder and pelvic limbs. You have normal cognitive function, and you can see what it is on MRI. You have no muscle. you have fatty infiltration, and so they have this typical presentation. Two distal arthrogryposis, as you can find in DA, and it's about mainly extremities. You have there are more than 100 genes that we can just know. We have most of time we have this kind of MRI, muscular MRI, where you find that the muscle they are, but they are not normal. So you can see what kind that we know until here, but maybe we can find some more. So it's something you can find in a family. The difference of the amyoplasia. And the third group, it is other one because you have CNS involvement without. You have all this kind of etiology. You have the very rare maternal causes where there is a problem with the uterus, and you have the connective disorders and environmental disorders. So in the third group, you can find really a lot of things, and you have often genetic pathology. So how to identify? So, like I said, clinical evaluation, because we can see something very particular, and paraclinical exams at the birth, very early in the first year. We do muscular MRI, malformative workup, cardiac, abdominal, and ophthalmoscopic fundus, and also what we, according to clinical perception, if we seem that there is a problem with CNS and muscle and bones. So the clinical evaluation must be very early at the birth, and it's the first time we see patients and his family. And arthrogryposis, it's a pathology that's beginning in the birth, at the birth, and continue until adults and aging people. And so it's the beginning of a story. So clinical examples are very particular. This joint dimple, and they are very frequent, and they are very specific when there is pain about this kind of mutation, distal arthrogryposis piezo 2. And so it's something you can see very early in the first year. Oh, sorry. You can have, by example, pterygia. Pterygia also, you can sometimes are very few pronouns, like this, or like this, and sometimes, you know, it will be a problem for the movement. Why it's interesting to know exactly the etiology of arthrogryposis, because just now we can, even if it's a rare pathology, we have a sufficient number of people to study the correlation between diagnosis and prognostic. By example, impact in walking, we know that this is amyoplasia in red and arthrogryposis in blue, and it's correlated. The infiltration of the liver is very well correlated to the 6-minute walk test, and it's correlated with the fatty infiltration and correlated with broken bone. So it's a pejorative thing. There is correlation with muscular strength, significantly lower in amyoplasia, and about joint limitation. So the diagnosis of amyoplasia is really more, it's c'est plus grave. The future will be lower. And we study also functional limitation, and it's the same about the prognosis of amyoplasia. So we are a rehabilitation doctor, and so we try to see what is growing with an AMC. It's a story of life. And so we have to do the project of the life, what with the family, what they want, what they dream about the children, and what we can go with this kind of children. So we need to have a good evaluation, an analytical, functional capacity, environment, lifestyle, and also to have a good objective and tools for rehabilitation and for the surgery. So rehabilitation is always developing participation, and so we need to improving function. So we have the objective, always think that it's for all life, and we have a lot of difficulty because of the joints do not have the physiological shape, because of the muscle or absence or poor quality, because we have to we have the problem of the fragility of the bones, we have the growth, we have to involve all the family, and for so many time. So arthrogryposis is a challenge for a surgeon because we have to give mobility and function with less pain as possible. And so normally what is able to do a surgeon, tendinoplasty, muscle lancing, muscle transplant, bone surgery, but we know just now there is no or few muscle, there is very thin bones, we don't know really where is the place of the cartilage, and there is multi-level abnormality. So in IMC, the surgeon has to take care of the etiology, seeing the function, seeing the growing, seeing the aging. Do not dream to restore normal function, normal morphology, and be sure of your rehabilitation team, because it's really an association you have to share. So why surgery? It's so difficult because the operative management, it's very special, because by example we have this difficulty because they really often have mandibular hypoplasia, and they are very difficult for tracheal intubation. They are difficult for the installation on operating table. They have very frequently complication. They they need rehabilitation with a team who know what is AMC in general and what is the patient, the special patient So the surgeon have to manage my aims for the useful and necessary mobility. You are sure that the joints will not be normal after surgery, so you have to know what is interesting. So in the upper limb, we think about one hand for eating, one hand for body care. In lower limbs, we have to know for For ambulation, symmetry and stability. So in hips, we have to only try to have a symmetrical posture. Two dislocated hips are sometimes accepted, but the future will be in a wheelchair. Not only one, even if the future is seated. It's the same about the knee, and it's the same in the knee. You don't have to dream about a normal flexion and extension. If you have an extension and it's okay. Ankle and foot, it's plantigrade posture, and very often there is no mobility. And don't forget the spine. It's the reason why it's arthrogryposis. It's a global pathology. At the birth, it's a moment where the joints limitation are maximal. But it's a reason why you have to have a clinical examination. Remember, it's a global disease. Remember, it's not surgery at the very early, but it's cast and orthosis, and it's orthopedic management. By example, if you take care of club foot, in AMC it's not idiopathic club foot, and it's special. And by example, you use the same method PON-CT, but we don't use the Denny Brown bar because there is very often no voluntary movement, and so it's not very interesting. We do cast every week for more time than in idiopathic club foot, because we did it for 6 or 8 weeks, and after we did the same percutaneous Achilles sections, and always think the foot with hips and knee. About the spine, what we know it's painful. It's vertebral malformations, 20%. It's very often scoliosis. We found in our register 46% in children and this in adults. So it's more frequent in arthrogryposis in DA than in amnioplasia. There is a lot of gene you can find in both the pathology, idiopathic scoliosis and AMC. The treatment is quite difficult because orthoses are generally inefficient. Surgery difficult, and also be careful in the functional prognosis, because very often they have very few mobility in the arms, and they use the spine to do a lot of things. And so if you do a surgery like this, and they have hands like this, they will do nothing more. So it's very special to analyze. So we recommend to do analytical checkup twice a year, connecting every people, physician, surgeon, and therapist. So we have to take carefully the range of motion of every joint, not forget the tiptoes, not forget analytical muscular testing. Why this assessment? Because it's very good to adapt or readapt patient care, to choose a major highlight of this care, and to choose with the child and with this family and with the adult people, and to see what is possible, what he wants to do, what the family wants to do, and so it's allowed to optimize patient's motivation and his personal investment. We have to analyze all the social participation, just how it's. So we have no specific functional assessments, you know, or certainly all these, shoulder, elbow, hand, standing position, movement, and walking. Different daily life situation, because it's help to do the project in the growing, and in the children and in the adults it's the same. And you have to assessment of the environment, because sometimes you need to maintain the human head, you need to adapt the architectural environment, and so you decide about the technical help, about the human head, and you analyze if you have to use very often or very rarely. So it's very important, because sometimes a material that we decide to buy is very expensive, so we have to be careful. In the rehabilitation, in all the sessions in France, we do it very often at home, or we learn to do it to the parents. And then we have to be very sure that everyone have understand that it's very important, no pain. It's mandatory to have the most accurate diagnosis, because the pains in piezo de presentation the pain is sometimes very, very important, even in the first year of the life. And every movement is very painful, and so we have to develop active movement and not passive movement. So passive work, it's every time, every day, for long session, very transmitted to the parents, and after transmitted to the people themselves, because the amplitude, the best time to growth, the joint amplitude, it's the third months in the life. So you have to begin your work very early after the birth. But all the life, and we see that when you stop, the joints turn back to the first. So you can use analytical muscle work, even if it's difficult, even if the muscles are not normal, but you can do or analytical, really, like in this, where we are working about quadriceps. And you can use, balneotherapy. You can use global muscular and endurance work through games, through sports, etc. And you have to use it even in aging. When growing, we try to develop mobility with what we call health mobility. We know about really different rehabilitation trends, and don't worry, you can imagine yours. And parents are very good relay team, because you can this technology, it was homemade by a mother. She was very interesting that her daughter was able to do, and she did this by herself. Or you can have a drawing, but it's a little more expensive. Global function, it's the good thing just now is to develop handisport, adapted physical activity. You have a lot of things like this. You can find them even if it's not a medical object, but you can find a lot of them, Dr. Google. And after, something very, very important in arthrogryposis are the braces. The braces for positioning to maintain what we obtain in the mobility. So set up as soon as possible. You have to decide in the first year you use them in the night and during the time baby is sleeping, and progressively you take care only the night. Sometimes you can use functional braces and be very attentive about pressure points and about materials. Very often we have new one, but not all are very interesting. So in the lower limb, nothing that you don't know, except we use, by example, this kind of articulation. It's very interesting for knee extension. And just now we have a little more in for the upper limb, but are very expensive, and sometimes national care don't pay them, so it's not. It's quite difficult to have them. And for the upper limb, you have to equipment very soon, and you have to know that these are the braces that we use for the birth to 6 months. So when I say, even if you need to change them every month, so you need to have orthosis team very able to do this very often. You can use also orthosis and as technical help. Some are really not expensive, like this. You have to analyze the situation to decide what is interesting to do, and after try to avoid the compensation, because when they do these kind of things when they are children, for all the infants, all the growth, when they are adults, sometimes they have really a lot of pain, and so sometimes you have to try to invent something different to help them to do the same movement, but in a way more economic for the bones. So you always need to adapt the daily light in prevention, what I was telling about joint and spine sparing, and so all the installation in schooling, working, and try to develop good compensation. The children find by themselves very often a lot of compensation, and so when they do by themselves, it's okay. Sometimes we have to adapt, and sometimes we have to do technical help to arrive for assistance for some walking and moving. So all daily life, all the life, you have to take care for what are able to do, for all they need to ergonomic attitude, to prevent pain in the aging, to do more and more in their life, and so found the compensation, makeup adaptation, very very cheap, like this. It's cheap, but you have to do them, or sometimes very expensive. And this is our team. We are a lot of people around this pathology. We are surgeon, we are genetics, speech and language therapy, physical therapy, and people who help us to analyze in genetics and all the adults, rehab, rheumatology, and pneumologist. So I hope just now you are very convinced that it's really important to know what is the pathology, what is the etiology to do good help, good surgery, good physiotherapy, etc. Thank you.
Thank you. Could you tell us up to what age do you use braces to correct posture for children?
At the birth.
Yeah, but till up to
After,
what age? Till adulthood?
Yeah. Sometimes when they are aging, children, sometimes they do not want more. So you have to explain, you have to try to maybe one hand, one night, and the other hand another night, and you have to show to the child that if he lose joint, he lose the function, and so he can be able to use it more, but normally very, very, very long time.
Thank you so much.
I have a question as well. Thank you again for the presentation. Myself, I don't have experience with pediatric rehabilitation, but I want to ask you, because you've mentioned the association of spine pathology, severe scoliosis, so the correction of a deformity in such a patient, because I don't think, so what is your opinion if surgery in spine deformity may correct the structural component, but from a functional level, is it any good or not in such a patient?
It's really difficult because it's depend. There is very often malformation, and so we don't know if it's good to have a surgery on the abnormal vertebra. If you have to see the spine in front and in sagittal, because very often they are very like this, because they can't go with the shoulder, with the elbow, so they go by this, and if you fix all the spine, it's...
You make it rigid.
Yeah, and sometime after they can't do anything more. So you have to do good team with the spine surgeon, because it's really difficult not to perjure the function. So it's a reason why. Is it okay for you?
For me, it's okay. This is what I wanted to hear. Thank you.
It's okay. So we talk about the next presentation.
It's you. So I introduce Dr. Gima. He's also a physical doctor. He works in Grenoble in a clinic who take care of orthopedic patient.
Thank you, Veronique. So I told you about the role and the place of rehabilitation after knee and hip arthroplasty, because in our center, I work in an orthopedic center of rehabilitation, and these surgeries are very frequent and common in France and in the world. So we just see that the place in the world of the rehabilitation for after the surgery. I have no conflict of interest. So quickly we will see the epidemiology of this surgery. After we talk about the goal of rehabilitation, how does it work in France, in Grenoble, and the perspective. For the total hip arthroplasty, we have a continuous worldwide increase. Within France, we have also this increase with 115,000 surgery per year. And if you look at this figure in the future, this increase are continue to increase regardless of the scenario that we make. So we have a lot of surgery now, and in the future we have a lot of surgery. Why this increase? Because the main cause of each surgery is due to the osteoarthritis with 62%, and the second to the fracture of neck of femur. So we have an increase of the surgery, but in our center in Grenoble, so the example of Grenoble, in 2021, we have just 379 requests for rehabilitation for THA, and on this request, we only take 96 people. And on the 96 people, 56 due to a fracture and 25 due to osteoarthritis. So we have a difference between the increase of a number of surgery and not so many people in rehabilitation. So we will see later why we have a difference between the cause of a rehabilitation, fracture, and the cause of a surgery. For the knee is also the similar. We have an increase of a number of surgery and indication in the world and in France for the woman and the man. But the difference is the main cause of the surgery is 19% of osteoarthritis, and the number is a little less than the THA. And another important fact is for the surgery of the knee, we have 20% of patients who are unsatisfied after the surgery. So this patient needs more complex or specific rehabilitation. So now let's see the goal of the rehabilitation. The first goal is not a specific rehabilitation, is to prevent the post-operative complication and to monitoring the post-operative complication. Because after surgery, we can have anemia, we can have an infection of the scale, so we need some doctor to monitoring this complication. We need to take some painkiller for an analgesia, and we also prevent the decubitus-related complication, which sometimes very important. So now we talk about the rehabilitation. For this presentation and the other slide, I take an example of a THA rehabilitation, and we separate the rehabilitation in two parts, one for the osteoarthritis cause of THA, and one for the fracture cause of THA, and we will see that we have a difference in the rehabilitation due to the osteoarthritis and the fracture. In this first goal of rehabilitation, it is very important to recover the function of the joint. For that, we work about the joint amplitude. We need more than 19 degrees of flexion of the hip. This improve of the joint amplitude, joint motion, can improve the posture of the patient. We can have better stand uprighting, and we need to work about the muscle, and particularly the gluteal muscle. We have no difference between osteoarthritis and fracture rehabilitation for this part, and all this rehabilitation in one specific therapist, the physiotherapist. Now, the second, once we have recovered the function of the hip, we need to resumption the activity. And we have some difference between osteoarthritis and fracture. Sorry for it. The first step, when you have a hip is functional, is to learn to walking. At the beginning with Christian, with Kellner, and after without technical aids. The second time is to learn to get up and go down the stairs and to improve their balance. It's the same for osteoarthritis and fracture. But when we have a fracture, most of the people have fall in their arm, so they can develop kinesiophobia, fear of fall, and we need to assess their psychological status, because a lot of patients after fall can develop a depression. So we need to prevent this failure of a psychological, so we need some specific therapist. And after a fall, we need to readapt the daily life activities. So we can see we have a different objective between osteoarthritis and fracture. So we need some specific therapist in fracture. So, which physiotherapist works? For the walking, stair, for the balance, we need physiotherapist. But when we have kinesiophobia, we need psychologists, or in France we have also a psychomotrician for work about the posture of the people, the fear of the fall. So we need more specific therapists, and we need occupational therapists for learn to daily live occupation, like kitchen, like bathroom. So we see that for the fracture, we need more and more specific and multidisciplinary rehabilitation. Once we have a resumption of the activity, you need to recovery of social participation, because the goal of a surgery is make the patient can restore their life before the osteoarthritis or the fracture. So we need to come to the patient to a social life, to our family lives, and you need to fall prevention. When you have a fracture, people can be afraid to going to their housing, because they can have fall in their house, so we can remember the fall. So we need to prevent the fall in their home, and we need to adapt their housing. Another way is people who have a fracture can also work again, so we need to prepare them after the discharge of the hospital to return to their work in different cases. And so for that, we have the social worker and occupational therapist. The social worker can adapt the time of the work, and occupational therapy the space of the work. So we see the difference with osteoarthritis, we have no therapists, and for fracture we need some more therapists and specific. If you want to resume, we need to work with the International Classification of Functioning. It's the base of rehabilitation. You have the body function, which connect with activities, which connect with participation. For example, when you have a fracture of your hip, you can move your hip, so you have a loss of function. That includes a loss of activity. You can walk, you can go in the stair, and this loss of activity includes a loss of participation. People who don't walk, who don't go in the stair, can't go out and can't have a family life. So we need to make rehabilitation not just for the physical problem, but for all the patient, all the globality of the patient. You need to rehab the physical and the psychological. And we have two other elements, environmental factor and personal factor. If people are alone, if you have they live in an isolated mountain, they influence their recovery and their condition. So if you can't resume in these all things, you can use the free air. The first R is rehabilitation. We need to recover functional abilities. This goal is different between osteoarthritis and fracture because when you have osteoarthritis, you have pain, so your pain decrease your functionality, you decrease your movement of your hip. So after surgery, you go have better functionality than before the surgery. And the difference in fracture, after the fall, you don't have any problem. So the goal of the rehabilitation is to get the same abilities as before the fracture. The second R is readjustment. You need to adapting the environment to new capacity of the people. After a fracture, you can prevent another fall in the bathroom. You can put a seat in the shower to prevent the fall. You can use a long tongue for check the telecommand and other thing, and you can, by this way you limit the risk of hip dislocation when you have excessive rotation and flexion of the hip. And you can use electric bike for go to right and to keep your activity. The third R is the reintegration. People after the chirurgy need to keep active. So they just need to have their physical activity, their social and family activity, and sexual activity. We need to restore all these things because people with the surgery need a new life. So now you talk about the international classification and how is work in France. What kind of rehabilitation after surgery? We have two main rehabilitation. The first is rehabilitation with ambulatory physiotherapist, and the second is rehabilitation in a rehabilitation center, in daycare center, or full hospitalization. We see the difference between the two. For ambulatory physiotherapists, people come home after the surgery, and we have a French system we call Prado. It's a French public health system. We ensure the coordination of health professionals. It's for patients after surgery, in maternity, people over 75 years old, or people who has decompensation of chronic pathology. How does it work? When you have a surgery, an advisor of a Prado comes to the hospital. They meet the patient, and together they check the need of the patient to return at the home. So before the discharge, the advisor of Prado call the general practitioner and find some nurse, some physiotherapist to prepare the discharge of the patient. It's a free system. So which patient can go into ambulatory physiotherapist? Most of the case is osteoarthritis. Patient we have a THA for osteoarthritis because, as can you see on the previous slide, they doesn't need a multidisciplinary team of rehabilitation. They just need physiotherapists so we can going out. But for this patient, we need to live in accessible housing and not isolated patient. Sometimes after an ambulatory physiotherapist, we have a failure of rehabilitation. And in this case, patient wants to see their children because they think it's a surgery problem. It's not the case. It's not a surgery problem, it's a rehabilitation problem, so they need to see the rehabilitation physician to start another rehabilitation in a center or other. Now we talk about the rehabilitation in center. In France, we have a national software we call Trajectoire. It's a software for the physician and the children who wants to have to send their patient in a rehabilitation center. How does it work? They make a request in this software, including the age, the name of the patient, the disease of the patient, and they select the rehabilitation center that we want. So if you have a stroke, you need a neurological rehabilitation, so you request a neurological rehabilitation in this software. For the physician rehabilitation, we have this page. Here we have the name of the patient, the age, the unit who make the request, and the disease. And when you click on the patient, you have this treatment, this past history, this independence, and where we live. With all this information, you can select the patient, and we can see which patient need rehabilitation in the center and which patient need rehabilitation with an ambulatory physiotherapist. So in rehabilitation center, we have a daycare center. For the patient, we have a fail with ambulatory physiotherapist, patient with adapting housing but need a complex rehabilitation after a fracture. The daycare center can be a relay between the full hospitalization and the ambulatory physiotherapist, because some rehabilitation is too complex for ambulatory physiotherapist, but too light for full hospitalization. So we make a relay in daycare center. And sometimes we have some patient before a surgery who come from daycare center. It's for complex surgery, and we make a pre-rehabilitation in daycare center to improve the patient before the surgery. We need to develop this part. From full hospitalization, it should be as short as possible. In France, after a total hip arthroplasty, sometimes it's 2 or 3 weeks. It depends for 3 particular criteria. People who have a specific prosthesis, like an infection prosthesis, a complex revision, a prosthesis and cancer, a traumatic prosthesis, need a multidisciplinary rehabilitation, so we can take them in rehabilitation center. The second criteria, if you have a specific patient. Patients who have repeated fall need to come to rehabilitation center, because we need to learn to prevent the next fall. We need to adapt their home, and we need to learn them to let up from the floor when we fall. So we take them in rehabilitation center. And we have patients with multiple disease. We can make decompensation after the surgery. And we have a lot of isolated, of elderly patients who live alone and they doesn't have help at home, so they take him in their center. The last criteria is the specific environment. An important part of a patient who are rehabilitation center is due to a lack of rehabilitator nearby or an adapted housing. So this patient can't have a rehabilitation after their surgery, so they have a loss of luck. So we need to take them into the rehabilitation. And we are in Grenoble in mountain house area, so we have a lot of chalet like this. So patients are completely isolated in the mountains, so we need to take them into rehabilitation center. For this patient who lives in the steep of chalet, we prepare the surgery at the good period of the year. They don't make this in the winter because we have snow. So we try to make this in the spring or in the spring of automne, printemps, spring. Well, in the spring. So, in brief resume, the indication of rehabilitation center for people who have simple osteoarthritis, they need less rehabilitation, so become an ambulatory physiotherapist. If you are poor environment, comorbidity, and complication of your prosthesis, they take them into full hospitalization. Most of the case is ambulatory physiotherapist because we have most of the case simple THA. For the fracture, is quite the same. We have simple fracture comes in ambulatory physiotherapist. Sometimes we have someone with daycare center. And if you have poor environment, elderly comorbidity, and prosthesis complication, we take him into full hospitalization. So we see that we have an increase of a number of surgery, but we don't have an increase of a number of beds in rehabilitation centers. So we need to develop different tools to prevent and to make the rehabilitation. And one of the perfect tool is the virtual rehabilitation. This rehabilitation is very developing in the Nordic country, like Denmark, Netherlands. So we have two examples. On your left, you have a system where patients are connected on a webcam in their home, and they are connected to a physiotherapist in a rehabilitation center, and they make the rehabilitation together with 20 patients. They are connect each other. This kind of rehabilitation can allow the physiotherapist to monitoring the rehabilitation of this patient. And if a patient doesn't make his rehabilitation, they come in rehabilitation center to make an assessment. The second type of virtual rehabilitation is like in Denmark, you have the own system, like a Kinect system. Patients are in their home and they make their rehabilitation alone in their home. And they doesn't have a control of a physiotherapist. So we can have some problem with this. Now we have talked about THA rehabilitation, and for the total knee arthroplasty, it's also the same thing. We have the free air, rehabilitation, readjustment, reintegration, were included in the international classification of functioning. And for the indication of the rehabilitation, most of the case is simple osteoarthritis, so they take ambulatory physiotherapists. And sometimes we have poor environment, prosthesis complication, most of the case is fear, or elderly patient and comorbidity, and they take them into full hospitalization. So to conclude, some message. All the rehabilitation starts with the surgeon. We need collaboration between surgeon and rehabilitator. The rehabilitator is adapted with each patient to each prosthesis. She is based on the international classification and functioning, and we need to develop new tools to rehabilitation, and maybe the virtual rehabilitation is the future of rehabilitation. Thank you.
Experience with us. I myself have a question. You've mentioned in the beginning of your slides, in the first slides, that regarding knee arthroplasty, so total hip, 20% of the patients are unsatisfied. Why do you think that is?
Because we think after the surgery, they don't have, they can make their life like before, and if they think that the surgery is the remedy of a problem, but sometimes in rehabilitation, where this patient doesn't have a flexion of more than 19 degrees, so we need to mobilize with anesthesia, and
yes, I understand, yes.
so they don't think about the complication about the surgery.
So the main, because we don't have any statistics, but let's say that the percentage might be the same in our country. So we have a percentage of patients that might feel unsatisfied post-surgery. So do you think this is regarding pain on daily activities or just range of motion and stability in the total hip replacement? What is your opinion? So
I think it's ability. I think it's ability because after they can make all the own activities that they make before the surgery. So I think it's the less ability is the problem for them.
Okay, and the second question, I have a couple more. The second you've mentioned, and I refer right now to the early phases of the rehabilitation, so immediately post-surgery. In case, let's say, of hip endoprosthesis for neck fracture, do you use, what kind of assistive devices do you use? Because you've put a picture with crutches. Do you use a walker or crutches at the early? What is your opinion regarding the risk of fall?
I think in France, in our center, we use two wheelchair because people doesn't want to work, you have pain. So we use a lot of wheelchair, and I think it's a bad idea because when patients have wheelchair, they just keep them, and sometimes 1 month after the surgery, we will keep the wheelchair. So
yes.
we need to
keep them dynamic.
Yes, and maybe for the elderly patient, the walker is better, and for young patient, crutch cane.
This is my point of view from my experience. So we use the walker. With wheelchair, definitely no wheelchair. So we don't use any wheelchair for any patient post-surgery. But we've tried in some patients using directly crutches, but we had some problems with instability and balance. Yeah. And we try to prevent the risk of falling. So this is why you use the walker first and afterwards
and
crutches.
You use walker with
with 4 legs, walker with 4 legs.
Yeah.
And afterwards we make the transition from walker to crutches.
Okay, so the walker you have...
no wheels on the walker.
No wheels?
No wheels.
We use 2 types of walker, one with 2 wheels on the top and one with 4 wheels. But the 4 wheel, it's very dangerous for the balance of the patient. So we can...
Yes, that's why we remove them as well.
Okay.
Okay, thank you very much for your point of view.
That's good. It's done. Thank you. Thank you. I think the session is closed. Thank you.